Hello again. So today we're going to continue talking about the cardiovascular system, and we're going to focus on the control of blood pressure. We've introduced that topic when we talked about what blood pressure was, but we're going to go into more detail on how our bodies maintain a relatively constant blood pressure throughout the day and what are we responding to when we make those changes. When we think about blood pressure control, there are two categories. We have what is called the short-term and hormonal controls, and then we have the long-term renal regulation. Okay, so there are things that make changes minute to minute. These will be short-term, and these are under the control of the nervous system, so neural, and the endocrine system, or hormonal. And so their main way of changing blood pressure is to do things that alter peripheral resistance. Okay, so think about vessel diameter and cardiac output. So think about like heart rate and stroke volume. So these are going to be minute-to-minute changes that you can do by changing vessel diameter and changing your cardiac output. Now, long-term regulation, this requires the kidneys, okay? And so the kidneys are going to be responsible for maintaining blood pressure long-term if needed, and they're going to do that by altering blood volume. So by changing the rate that they filter and form urine, and thereby changing blood volume, is one way of regulating the blood pressure. So we're going to go through each one of these and talk about specifically how it works. So some of these neural controls, remember these are short-term. You do this by maintaining, or to maintain your mean arterial pressure, your MAP, you do that by altering blood vessel diameter. Okay, so again, this is done in the short term. So you would send out a nervous signal to the vessel and cause it to either vasoconstrict or vasodilate. Okay, and so you can also use this same mechanism to shunt blood. So by changing the diameter of a vessel, you can either restrict blood flow to an organ, or you can have normal blood flow to an organ. So we use these neural controls by changing vessel diameter to either increase peripheral resistance, which increases blood pressure, or to move blood from one area to the other to distribute blood to organs in response to a specific demand. Okay, so we've kind of talked about that, how if you're cold or hot, you can shunt blood to or away from your skin. These neural mechanisms, they work using a reflex arc, and hopefully you remember what a reflex is from your first anatomy. And these receptors are called baroreceptors. So you have to have a receptor when you're talking about a reflex. And baro, like barometer, so you think barometer is like what you use to measure the air pressure, like if a hurricane's coming. So a baroreceptor is measuring the pressure, and so in this case we have carotid sinus baroreceptors, which are in the carotids. We have baroreceptors in the aortic arch, and then we also have them in some large arteries in the neck and thorax. And so you have the baroreceptors, but you have to have a control center. So remember, reflexes have to have some kind of control center. And these are not going to be higher order thinking. They're going to be more reflex, so you're thinking spinal cord or brainstem. So you have a cardiovascular center in your medulla. Okay. You have to have some kind of output, so you've got to have some fibers, some efferent nerves. So you have vasomotor. So remember, motor is efferent fibers that leave and go out to the heart and those vascular smooth muscles. Okay, and sometimes in addition to these baroreceptors, you also use chemoreceptors, okay, in your higher brain centers. And those are used in particular when you're talking about changes in CO2 levels and changes in O2 and pH. So specifically, a rise in CO2 or a drop in O2 and pH will stimulate chemoreceptors, and that will also can play a role in short-term neural control of blood pressure. So how does this look? So you have some sympathetic neurons in your medulla, and they are basically overseeing changes in cardiac output. This is not carbon monoxide, so cardiac output and blood vessel diameter. They're kind of watching out for that. And so you have this vasomotor center inside this part of your brain, which is going to send out steady impulses via sympathetic, remember that fight or flight, to blood vessels. And this is going to cause what's called vasomotor tone. And so this is what keeps your blood vessels kind of toned and ready at all times. So your blood vessels are always slightly constricted, okay? We talked about that with skeletal muscle tone, how your sarcomeres are always slightly engaged and you're always slightly contracted, so you're kind of ready to go. So your blood vessels are under the control of the sympathetic nervous system to maintain vasomotor tone, so they're not just flaccid and completely open. If all your vessels were completely dilated and they were completely open, your blood pressure would drop to nothing. So you've got to have something maintaining blood pressure, and we call that vasomotor tone. Now we can respond if we need to increase or decrease our blood pressure and make changes to that vasomotor tone. That's going to be in response to changes like inputs from our baroreceptors or chemoreceptors in our higher brain centers. So if we need to respond with higher blood pressure or lower blood pressure, we're going to do that using these baroreceptors, chemoreceptors, and higher brain centers. Okay? I think that made sense. Made sense in my head anyway. All right, so let's talk about how this looks on the old teeter-totter. I know we've done this a lot of times. So let's start with our stimulus, because remember, you always have to have a stimulus. Okay, so the stimulus is rising blood pressure. So this is blood pressure above a normal range. Okay, so you need to respond to something going out of normal. So you've got baroreceptors in the carotid sinuses and the aortic arch, and they're going to respond to this increased pressure. That's going to send an increase in these stimuli, an increase in these impulses from these baroreceptors will stimulate cardioinhibitory centers. Okay, you're going to stimulate a cardioinhibitory center, and you're going to inhibit a cardioacceleratory center. All right, makes sense? So you're going to stimulate something that's going to slow the heart down, and you're going to inhibit something that speeds the heart up. All right, you're going to inhibit the vasomotor centers. So you've got two signals going out. So you've got this one, which is going to cause, if you decrease the rate of vasomotor impulses, then the vessel will vasodilate. That's going to decrease peripheral resistance. If you decrease peripheral resistance, what happens? You decrease blood pressure, right? Blood pressure goes back down. If you are inhibiting those cardiac acceleratory centers and you are stimulating those cardioinhibitory centers, then that means you're going to decrease the amount of sympathetic impulses that go to the heart. That's going to cause the heart rate to go down. That's going to cause contractility to go down. That's going to cause cardiac output to go down. All right. So if cardiac output is going down and resistance is going down, blood pressure is going down. Remember, they go in the same direction. So blood pressure is going down because you have slowed down the heart, okay, and you have increased the diameter of the vessels. All right, that makes sense? So your heart rate and vessel diameter is going to get bigger, and the blood pressure is going to drop. And so that's going to negatively feed back, and that's called negative feedback because now you've shut off the original stimulus. Now what happens if your stimulus is the other way? You have falling blood pressure. Okay, so falling blood pressure. Your arterial blood pressure is falling below the normal range. Well, we don't want that to happen because that's going to impede the perfusion rates that are going and taking blood to our brain and other organs. So we need to get our blood pressure back up so we can keep that blood flow up. So again, baroreceptors are going to respond to that change, and the way they respond is they're inhibited, okay, because they're not firing, they're not being stimulated. So you're going to get fewer impulses from those baroreceptors, which is going to activate the cardioacceleratory center and inhibit the cardioinhibitory center, and going to stimulate the vasomotor center. So what does that mean? Remember, vasomotor tone is vasoconstriction, so it's going to cause those vasomotor fibers to constrict against the blood vessel. That's going to increase peripheral resistance. All right, you're going to increase sympathetic tone to the heart. You're going to cause an increase in heart rate, an increase in cardiac contractility, an increase in cardiac output. Well, if you're increasing cardiac output and you're increasing peripheral resistance, that's what the R is, you're going to increase blood pressure. So your stimulus is now going, your response is going in this direction, which is opposite from your stimulus, which means it's negative feedback. Okay? So this is what's going on kind of all the time. Your blood pressure is responding to changes in maybe your activity level, maybe your need to run away and run down the steps real quick to go to the bathroom, or maybe you've laid down and you've sat up, or you've had a lot of salt and maybe now you're retaining lots of fluid, so you've got a lot of volume, and so you're just trying to figure out, your body's trying to regulate blood pressure. So it's kind of always kind of fluctuating on this teeter-totter between speeding up and slowing down the heart and dilating and constricting the vessels. Okay? So again, this is a great example of how the baroreceptor reflexes help maintain homeostatic levels of blood pressure through negative feedback. Now, again, you can have short-term mechanisms that use chemoreceptors. And so again, you have, just like you had baroreceptors, you have chemoreceptors in your aortic arch and some of your large arteries. And they will notice or detect an increase in carbon dioxide, a drop in pH, or oxygen levels. Okay, so if I say drop in pH, is that acidic or alkaline? So decreased pH means it's becoming acidic. Okay, so you're seeing your blood become acidic. So what you may not know is the impetus, your drive to breathe is really not because you need oxygen, it's to get rid of CO2. So if you hold your breath, what makes you want to breathe is blowing off the CO2. You have a buildup of CO2 in your body, which causes a production of acid called carbonic acid, drives your pH down, and that's your drive to breathe. And we'll talk more about acid-base balance later. So if your chemoreceptors pick up an increase in CO2 levels, that means we need to do something to get rid of more CO2, okay? And so what you're going to do is increase your blood pressure so you can start moving more CO2 out through your lungs. And so this is going to increase signaling to the cardioacceleratory center to increase cardiac output, and to the vasomotor center to increase vasodilation. Well, if you increase both of those, what's going to happen? Increase cardiac output, increase vasoconstriction. That's going to increase peripheral resistance. So you're going to increase what? Blood pressure. All right, some other things, short-term mechanisms that need the higher centers of the brain to be involved. The hypothalamus and the cerebral cortex can also modify arterial pressure via the medulla. Okay, so you can have higher brain powers kind of working through the medulla to increase blood pressure or modify blood pressure. The hypothalamus can also change blood pressure during stress by releasing hormones. So think about like adrenaline. So you can release hormones when you need to increase blood pressure in response to stress or that fight or flight mechanism. There's other hormones as well. We're going to talk about different hormones as we move through. The hypothalamus also can mediate the redistribution or the movement of blood from one part of the body to another, especially during exercise or when you are having changes in temperature. So when you're exercising, you want to increase blood flow away from the digestive system, but to the muscles and to the skin so that you can dissipate heat. If you're just sitting there after Thanksgiving dinner, you're just going to change and move blood away from the skin, away from the skeletal muscle, and to the digestive system. So we're always moving blood to wherever we need those organs to be have good tissue perfusion, and that can also mean that we need to change our blood pressure as well to help us regulate the blood flow to those different areas. That's why when you exercise, you may, if you're exercising, you kind of feel your heart beating really, really hard. And so if you might take your blood pressure during exercise and you'd realize your blood pressure has actually gone up. I know if you go to the doctor and maybe you're running late and you're running, and you just come right in right before your appointment time, and maybe you're kind of hot and sweaty, and they take your blood pressure and like, oh, your blood pressure's high. Well, maybe you need to tell them, well, I just ran. Okay, give me about 5 minutes to calm down, rest, relax, and my blood pressure will go back down. All right, so some hormonal controls. These are also short-term mechanisms that require hormones, and the way you can increase blood pressure using hormones specifically are using epinephrine and norepinephrine. You may have heard of those as adrenaline, noradrenaline, but they're the same thing. And these are from the adrenal gland, so they're going to be released in response to stress, and they will increase cardiac output and vasoconstriction. So if you increase cardiac output and increase peripheral resistance, you increase blood pressure. Another hormone is called angiotensin II, and it's a hormone that will cause vasoconstriction. So if you vasoconstrict, what happens? Increased peripheral resistance, increased blood pressure. ADH, which stands for anti-diuretic hormone. So you guys may or may not have learned your endocrine organs yet, but anti-diuretic, or your hormones yet. Anti-diuretic hormone, so let's break that down. Anti-diuretic. So if you diurese, you do what? You make urine. So if you anti-diurese, you stop producing urine. So if you're not making urine, then you're not getting rid of excess fluid. So that means you're going to have excess fluid in your body, right? Okay, so anti-diuretic hormone is going to keep you, it's going to allow you to maintain fluid in your system. Well, if you have more volume in your system, more blood volume, what happens to your blood pressure? It increases. It also can cause vasoconstriction, so that increases peripheral resistance, increases blood pressure. Hormones that can lower blood pressure, atrial natriuretic peptide, and that's a hormone that's produced by the heart, and it can cause a decrease in blood volume. Okay, so it decreases blood volume by what's called antagonizing or doing the opposite thing of aldosterone. And both of these hormones help play a role in sodium balance, okay? So we're going to, when you do your endocrine system, you're going to learn more specifically about these particular hormones, but they both play a role in how we balance sodium. So what's the one rule we know about sodium? Water follows sodium, right? So if you have sodium, and it's going to draw water to it. So if you have more sodium in the blood, you're drawing more water to the blood, you're going to increase blood pressure, right? If you're getting rid of sodium, then water is going to follow that sodium, decrease the blood volume, decrease the blood pressure. So by regulating the amount of sodium that you have, you can also regulate your water volume, your blood volume, and therefore your blood pressure. So blood pressure is pretty complex. It's a lot harder to understand than people realize. There's a lot of things going on. I like to joke that if people that have high blood pressure, cardiologists think it's all about the heart, but your nephrologist, your kidney doctors, they think it's all about the kidneys. It's really a combination of both, but it depends on who you ask. I typically spent most of my time studying blood pressure from the kidney end, so I tend to think it's the more important organ. But if you study cardiology, you'll tend to think it's more important. So it's really what your focus is. But they actually play an equal role, and they're both important. But the kidneys play a role long term. Okay, so these other things we've talked about, neural controls and hormonal controls, are short term, minute to minute, hour to hour. But renal regulation can be long term. And when the kidney kind of tries to kick in, it tries to help when your blood pressures cannot be controlled by those short term neural mechanisms or those short term hormonal mechanisms. You've kind of gone past their ability to control blood pressure. Because what happens is that these baroreceptors, they quickly adapt to chronic high and low blood pressures, and they become ineffective. So it's almost like, if you think back to if you learn about the special senses and maybe smell, you have sensory adaptation, where you walk into a room and you smell a nice candle, and then 5 minutes later you don't smell it anymore even though it's still burning. Well, the baroreceptors are like, okay, yeah, there's high blood pressure. We've done all we can do. We're gonna ignore it. And so now we need the kidneys to kind of come in and go, okay, we're going to take over, and we're going to alter and control blood pressure by altering the amount of blood volume. And we're going to do that by forming more or less urine. Okay, so we're going to alter blood volume by filtering the blood and making urine. So the kidneys can regulate arterial blood pressure either directly or indirectly. So there's a direct renal mechanism and an indirect mechanism. In the indirect mechanism, you need to include the renin, angiotensin, aldosterone system. Okay, so these are going to be a hormonal-driven mechanism. So the direct renal mechanism, this is altering blood volume independently of hormones. Okay, so this is just an increased blood volume or increased blood pressure is going to force the kidneys to filter faster, make more urine to reduce the blood pressure. So it's almost like think about a coffee filter. If you want to make the coffee faster, you put more water and more coffee and kind of force it through. You kind of push that coffee through instead of letting it drip through. So the higher the blood pressure, the more the volume, the kind of more you're going to force those kidneys to work and make more urine, reduce blood volume, and reduce blood pressure. If you have a decreased blood pressure or a decreased blood volume, that's going to slow filtration of the kidneys down. They're going to not make as much urine. That allows you to retain fluid, so retain blood volume and increase blood pressure. Okay. So that's direct. So just think about a change in pressure. So the higher the pressure, the faster the kidneys are working. To get rid of excess fluid, to lower your blood pressure. If your blood pressure is already low, then you don't have that force driving it, so it allows you to retain more fluid, hold on to that blood volume, and raise your blood pressure back up. So that's kind of the direct mechanism. The indirect mechanism requires renin, angiotensin, and aldosterone. Okay, so a falling arterial blood pressure will cause the release of renin. And we're going to do this again when we get to the kidney. I'm kind of introducing it to you now, and we're going to do it again. So what renin does is it catalyzes, like an enzyme, it catalyzes the conversion of angiotensinogen to angiotensin 1. So it turns angiotensinogen, which is made in the liver, to angiotensin 1. And you have another enzyme called angiotensin converting enzyme, or ACE, which converts angiotensin 1 to angiotensin 2. All right, so this is the active. This is what we want to get to, angiotensin 2. And you'll see it written as A2 a lot. So what does angiotensin do? It increases blood volume. So if you increase blood volume, that's going to increase blood pressure. Remember? Well, the way it does that is it causes the production or stimulation of more secretion of aldosterone. Okay? It causes antidiuretic hormone to be released, and it triggers your thirst centers. All right? So aldosterone, again, that's one of these sodium hormones. And we haven't done endocrine yet, so or you may have. It depends on which semester and which order we've done it. But I don't think you've probably had endocrine yet. So these are two of the hormones that play a role in increasing blood volume. Again, aldosterone works by changing sodium, helping you regulate sodium levels. And antidiuretic hormone basically slows down the diuretic, or slows down how much urine you make. So angiotensin also causes vasoconstriction of blood vessels. All right, so let's kind of put all this on a chart and see how this works. So the goal here, so this is the direct and the indirect mechanisms of regulating blood pressure using the kidney. Okay, so using the renal control. And so the goal here in both of these is to increase arterial pressure. So that means the stimulus must have been falling arterial pressures. So in the direct renal mechanism, if the pressure is falling, that's going to slow down filtration, that's going to slow down urine formation, which is going to mean you're retaining fluids, which is going to allow your blood volume to go up, which will increase your blood pressure. All right, that's the direct one, that's the force one. The indirect one, you need those hormones involved. All right, so here's your stimulus, falling blood pressure. We want to get it back up. What do? Well, your baroreceptors are they recognize this, okay, and they increase the sympathetic nervous system activity, okay, which causes the release of renin from the kidneys. All right, so the renin comes out. It causes that conversion of angiotensinogen to angiotensin 1, and then angiotensin converting enzyme, or ACE, causes a conversion to angiotensin 2. This is what we want to see what its effects are. Angiotensin 2 is then released. It goes to the adrenal cortex, causes the release of aldosterone. Aldosterone is a hormone that increases sodium reabsorption. So you're reabsorbing sodium. Where does water go? If you're holding on to sodium, you're holding on to water, you're increasing your blood volume, you're increasing your blood pressure. All right. Angiotensin 2 also increases the release of antidiuretic hormone by the pituitary gland. So this increase in antidiuretic hormone, so you're increasing antidiuretic. That means I don't want to pee, okay? So I want to hold on to water. So you're increasing water reabsorption. You're not making as much urine. increasing blood volume, increasing blood pressure. Angiotensin II causes your hypothalamus to turn on the thirst response, makes you thirsty. You drink more water. Increased water intake increases blood volume, increases mean arterial pressure. All right, angiotensin II goes to the blood vessels. All right, causes vasoconstriction. That increases peripheral resistance. If you increase peripheral resistance, you increase arterial blood pressure. Okay, so it's really complex, but I would encourage you to maybe make a copy of this particular slide and kind of go through and maybe cut these out and see if you can figure out where they fit. It's kind of like a drag, make your own drag and drop, and see the difference between the direct renal mechanism and then the indirect. All right, and also think back, see if you can figure out what happens if my stimulus is rising blood pressure. So that's kind of on you. I want you to think about this critically. Okay, what's going to happen? Do I need more aldosterone? Do I need more ADH? Do I need to be thirsty? Do I need to not be thirsty? Do my vessels need to vasodilate? Do my vessels need to vasoconstrict? What happens when my blood pressure is rising? Okay, so that's on you to kind of think about the opposite effect of what I've just shown you. All right, that's called critical thinking, so you guys should be able to do that. All right, so we have talked a lot about blood pressure, and now I want to put kind of everything together, and let's think what factors can increase mean arterial blood pressure. What can we do to increase blood pressure? Because we've talked about a lot of different things, okay? So we're going to put it all together in this slide. So if you increase the activity of the muscular pump and respiratory pump, so you're going to increase venous return, what's that going to do? Increase stroke volume, increase cardiac output, increase blood pressure. What if you decrease the release of atrial natriuretic peptide, ANP? Well, that causes your kidneys to increase the conservation of sodium. That's going to make you hold on to water. That's going to make you increase your blood volume, increase the amount of venous return you have, increase your stroke volume, increase your cardiac output, increase your blood pressure. What happens if you have huge fluid loss or a hemorrhage or a lot of sweating? Your blood volume goes down, your blood pressure goes down. Those baroreceptors are going to be activated. That's going to cause your heart rate to go up. It's going to cause your vessels to vasoconstrict, increase peripheral resistance, and increase cardiac output to increase blood pressure. What if you're stressed? What if you're exercising? What if you've had trauma? What if your body temperature's up? That's going to cause, again, your heart rate to go up. It's going to cause changes in blood pH. It's going to cause your chemoreceptors to fire. Again, changing the diameter of the blood vessels and the heart rate, increasing blood pressure. What if you increase your vasomotor tone? All right, what if something like stress, again, increase vasomotor tone, sympathetic nervous system, going to decrease those diameter of the blood vessel, increase peripheral resistance, increase blood pressure. What if you're dehydrated? That's that viscosity thing we talked about, or a high hematocrit. Maybe you've got some kind of cancer giving you too many red blood cells, or maybe you're taking EPO. Increase blood viscosity. That's way back in an earlier talk. Increase peripheral resistance. Increase body size. Because remember, I told you, increase in blood vessel length doesn't necessarily happen on a day-to-day basis, but if you gain weight, you can get increased blood vessel length because you're bigger. And so increase peripheral resistance, increase blood pressure. That's why people that are obese have problems with their blood pressure. All right, so all of these things. So I guess you're probably thinking by now, boy, this is going to be one heck of an essay or all but a blah question. And you're right. So there's a lot to blood pressure, okay? All right, and that's all we're going to talk about with blood pressure. All right, thanks a lot, and I'll see you in the next video. That was a long one. I apologize. I'll try to keep the next one a little shorter.